Rhinosinusitis, obstruction of sinus drainage into nasal cavity. Then there is inflammation and pain over the affected area. Typically affects the maxillary sinuses which drain against gravity due to ostia located superior medially. The red arrow what we see points to the fluid filled right maxillary sinus. Superior meatus drains the posterior ethmoid, middle meatus drains frontal, maxillary and anterior ethmoid, inferior meatus drains the nasolacrimal duct. Acute rhinosinusitis is most commonly caused by viruses, example rhinovirus. It may lead to superimposed bacterial infection, most commonly non-typable H. influenza S. pneumoniae M. catarrhalis. Paranasal sinus infections may extend to the orbits, cavernous sinus and brain, causing complications like it could be orbital cellulitis or cavernous sinus syndrome or meningitis. Next condition is epistaxis or nosebleed. Most commonly occurs in the anterior segment of the nostril or Kisselbach's plexus at the caudal septum. Life-threatening hemorrhages occur in the posterior segment. The sphenopalatine artery, a branch of maxillary artery. Common causes include foreign body trauma, allergic rhinitis, and nasal angiofibromas, common in adolescent males. Kisselbach drives his Lexus with his legs, is the mnemonic. So to remember, superior labial artery, anterior and posterior ethmoidal artery, greater palatine artery and sphenopalatine artery. That is the mnemonic legs. Labial artery, ethmoidal, greater palatine artery and sphenopalatine artery. Head and neck cancer. It is mostly the squamous cell carcinoma. Risk factors include tobacco, alcohol, HPV-16 or the oropharyngeal carcinoma, and EBV is the nasopharyngeal carcinoma which causes that. And field cancerization, that is carcinogen damages wide mucosal area, following which multiple tumors that develop independently after exposure. Nasopharyngeal carcinoma may present with unilateral nasal obstruction, discharge epistaxis. Eustachian tube obstruction may lead to otitis media with or without effusion and hearing loss. Laryngeal papillomatosis. It is also called the recurrent respiratory papillomatosis. Benign laryngeal tumor commonly affecting areas of stratified squamous epithelium such as the true vocal cords, especially in children, possibly from HPV transmitted from mother to baby during labor, associated with HPV-6 and HPV-11. Symptoms can guide location of pathology. Supraglottic lesions can cause dysphagia. Infraglottic or glottic lesions can cause hoarseness. Deep vein thrombosis. Blood clot within a deep vein causes swelling, redness, warmth and pain, which is predisposed by the virtuous triad or she. She or S for stasis, H for hypercoagulability and E for endothelial damage. Stasis can happen because of due to post-operative conditions, long drives or flight. Hypercoagulability seen with defect in coagulation cascade proteins like factor V lead in oral contraceptive use, pregnancy. Endothelial damage, exposed collagen triggers clotting cascade. DVT of the proximal deep veins of lower extremity, example iliac, femoral, popliteal, they are the source of emboli. D-dimer test may be used clinically to rule out DVT if disease probability is low or moderate. High sensitivity and low specificity of this test. Imaging test of choice is compression ultrasound with Doppler. Imaging test of choice is compression ultrasound with Doppler. Use unfractionated heparin or low molecular weight heparins like enoxaparin for prophylaxis and acute management. Use direct anticoagulants like rivaroxaban, apixaban for treatment and long-term prevention. Next condition is pulmonary emboli. Obstruction of the pulmonary artery or its branches by foreign material, usually thrombus, that originated elsewhere. Affected alveoli are ventilated but not perfused, that is VQ mismatch. May present with sudden onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, respiratory alkalosis. Large emboli or saddle embolus may cause sudden death due to clot preventing blood from filling the left ventricle and increased right ventricular size, further compromising the LV filling. It's obstructive shock. CT pulmonary angiography is imaging test of choice for pulmonary embolism. Then ECG may show sinus tachycardia or less commonly S1Q3T3 abnormality. Lines of Zan are interdigitating areas of pink that is platelets and fibrin, and red that is RBCs found only in the thrombi formed before death. Helps to distinguish pre and postmortem thrombi. Treatment is anticoagulation. Example, heparin, direct thrombin or factor 10A inhibitors. IVC filter if anticoagulation is contraindicated. Types: fat, air, thrombus, bacteria, amniotic fluid, tumor. So the mnemonic is an embolus moves like a fat bat. So these are the ones which can become emboli. Fat emboli, it is associated with long bone fractures and liposuction. Classic triad of hypoxemia, neurologic abnormalities, and petechial rash can be found in this. Air emboli, nitrogen bubbles precipitate in ascending divers, also called as a Caisson's disease or decompression sickness. Treatment is with hyperbaric oxygen, or it can also be iatrogenic secondary to invasive procedures like central line placement can cause air emboli. Amniotic fluid emboli typically occurs during labor or postpartum but can be due to uterine trauma. It can lead to DIC, rare but high mortality. Next, coming to the mediastinal pathology. Normal mediastinum contains heart, thymus, lymph nodes, esophagus, and aorta. Mediastinal masses. Some pathologies like lymphoma, lung cancer, abscess can occur in any compartment, but there are common associations. Anteriorly, we have four T's, that is thyroid or the substernal goiter, thymic neoplasm, teratoma, and the terrible lymphoma. Middle ones, metastasis, hiatal hernia, bronchogenic cyst. Posteriorly, esophageal cancer may present as mass in or spread to middle mediastinum, neurogenic tumor, example neurofibroma and multiple myeloma. Mediastinitis is inflammation of the mediastinal tissues, commonly due to post-operative complication of cardiothoracic procedures before 14 days, and esophageal perforation or contiguous spread of the odontogenic or retropharyngeal infections. Chronic mediastinus, also called as fibrosing mediastinitis, due to increase in the proliferation of connective tissue in mediastinum. Histoplasma capsulatum is common cause. Clinical features include fever, tachycardia, leukocytosis, chest pain, and sternal wound drainage. Pneumomediastinum is presence of gas, usually air in the mediastinum. Can either be spontaneous due to rupture of pulmonary bleb or secondary, example trauma, iatrogenic Boerhaave syndrome. Ruptured alveoli allow tracking of air into the mediastinum via peribronchial and perivascular sheaths. Clinical features include chest pain, dyspnea, voice change, subcutaneous emphysema, and Hammond sign, that is crepitus on cardiac auscultation. Next, looking at the flow volume loops. So we look at the flow volume parameter, normal, obstructive lung disease, and restrictive lung disease. What happens to each of these parameters? So residual volume, it is increased in obstructive lung disease, decreased in restrictive lung disease. Functional residual volume, increased in obstructive lung disease, decreased in restrictive lung disease. Total lung capacity, increased in obstructive diseases, decreased in restrictive diseases. FEV1, in normal it is more than 80% predicted, and obstructive lung diseases markedly decreased, restrictive lung disease decreased. FVC, it is normally it is more than 80%, and obstructive lung disease decreased, and even restrictive lung disease it is decreased. The FV1 by FVC ratio, it is more than 70% in normal, and decreased in obstructive lung disease. FEV1 is decreased more than FVC, whereas restrictive lung disease it is normal or increased FEV1 decreased proportionately to FVC. So we are seeing this curve, whereas in an obstructive disease the loop shifts to the left, whereas restrictive loop shifts to the right. Next, obstructive lung diseases. So obstruction of airflow, there is a marked decrease FEV1, decreased FVC, decreased FEV1 and FVC ratio. So there is air trapping in the lung. So high residual volume, it leads to an increased functional residual capacity and increased total lung capacity due to premature airway closure at high lung volumes. It includes COPD, chronic bronchitis and emphysema, asthma and bronchiectasis. Chronic obstructive pulmonary disease, COPD itself, often due to tobacco use. It's the most important risk factors. Other causes are pollutants or allergens. Includes chronic bronchitis and emphysema, which often coexist. Exacerbation can cause acute worsening of symptoms, often associated with viral or bacterial upper respiratory tract infection. Chronic bronchitis, the diagnosis is more a clinical diagnosis. The criteria are productive cough for more than or equal to 3 months in more than or equal to 2 consecutive years. May also have dyspnea, wheezes, crackles due to mucus cyanosis because there is hypoxemia due to shunting, and secondary polycythemia. It can lead to metaplasia of the pseudostratified ciliated columnar epithelium into stratified squamous epithelium. The mechanisms for chronic bronchitis are hypertrophy and hyperplasia of the mucus secreting glands in the bronchi. So additionally notes increase reed index, that is thickness of mucosal gland layer to thickness of the wall between epithelium and cartilage is more than 50%. Next, emphysema. The diagnosis is radiologic or biopsy diagnosis. In X-ray, the chest appears barrel with an increased anterior posterior diameter and a flattened diaphragm with an increased lung fluid lucency. Mechanisms are the alveolar wall destruction. There is an increase in the compliance of the lung, decreased recoil and damage to alveolar capillary membrane. So there is decreased DLCO, results in increased air space. Centriacinar, that is it spares the distal alveoli, frequently in the upper lobes associated with tobacco smoking. Panacinar, it affects respiratory bronchioles and alveoli, frequently in the lower lobes associated with alpha-1 antitrypsin deficiency. So additional notes, mediated by oxidative stress, chronic inflammation. So there is a CD8 plus T cells, neutrophils and macrophages, and imbalance of proteases and antiproteases. There is an increase in the elastase activity and increase in loss of elastic fibers, alveolar destruction. Defect or deficiency or absence of alpha-1 antitrypsin leads to unopposed elastase activity. Alpha-1 antitrypsin is an antiprotease that inhibits the neutrophil elastase. Next condition, asthma. It's an intermittent obstructive lung disease often triggered by allergens, viral upper respiratory tract infections, stress associated with atopy. It is NSAID or aspirin exacerbated respiratory diseases are asthma, nasal polyps and COX inhibitor sensitivity. So there is an increase in the leukotriene overproduction causing airway obstruction. It is called the Samter's triad. So diagnosis of asthma is clinical, intermittent episodes of dyspnea, coughing, wheeze, tachypnea. Diagnosis is supported by spirometry. So spirometry shows an obstructive pattern with bronchodilator response but may be normal when not in exacerbation, with or without methacholine challenge. Diagnosis is by spirometry with or without methacholine challenge. Mechanisms, type 1 hypersensitivity reaction, where there is smooth muscle hypertrophy and hyperplasia, hyperresponsive bronchi, reversible bronchoconstriction, mucus plugging. Additionally, Kirschmann spirals. It is a shed epithelium which forms old mucus plugs. Charcot-Leyden crystals are eosinophilic hexagonal double pointed crystals formed from the breakdown of eosinophils in the sputum. Next, bronchiectasis is an obstructive lung disease most commonly associated with cystic fibrosis. The diagnosis is characterized by chronic cough and daily purulent sputum production. Often have recurrent pulmonary infections confirmed by imaging demonstrating airway dilatation and bronchial thickening supported by obstructive PFT pattern. Pathophysiology: initial insult of pulmonary infection combined with obstruction or impaired clearance causes a dysregulated host response, which in turn causes bronchial inflammation and finally permanently dilated airways. So additionally, notes many etiologies including airway obstruction, example foreign body aspiration mass, poor ciliary motility because of tobacco smoking or carcinogenous syndrome, cystic fibrosis, um, allergic bronchopulmonary aspergillosis, pulmonary infections due to Mycobacterium avium are all the etiologies. So we are seeing here pictures of different specimens. So the first one, A, is showing a barrel chest, most commonly seen with the emphysema. Next is what we are seeing is alveolar wall destruction. This B showing the walls of the alveolar are destroyed. Next in C is showing associated with tobacco smoking, that is Sentry SNR. Both C and D are showing Sentry SNR type of emphysema. Next E is mucus plugging, showing mucus plugging. Then F for Kirschmann spiral. These are the Kirschmann spirals here. F. G is eosinophilic. G is Charcot-Leyden crystals. These are the Charcot-Leyden crystals. H is it's showing a coughed up inspissated mucus plug. Moving on, restrictive lung diseases may lead to decrease in the lung volumes. There can be a decrease in FVC and TLC. PFTs are normal or increased in the FVV1 FVC ratio. Patient presents with short, shallow breaths. Types are different types of the diseases. One is altered respiratory mechanics. Extrapulmonary, normal DLCO, normal AA gradient. It could be due to respiratory muscle weakness like poliomyasthenia gravis, Guillain-Barré syndrome, ALS. Chest wall abnormalities because of scoliosis and severe obesity. Next is diffuse parenchymal lung disease, also called as interstitial lung disease. It is pulmonary. There is a decreased DLCO and increased AA gradient. Causes are pneumoconiosis, or example, coal workers pneumoconiosis, silicosis, asbestosis. Sarcoidosis, there is bilateral hilar lymphadenopathy and non-caseating granulomas. There is an increase in the ACE and calcium. Other causes: idiopathic pulmonary fibrosis, granulomatosis with polyangiitis, pulmonary Langerhans cell histiocytosis, also called eosinophilic granuloma, hypersensitivity pneumonitis, drug toxicity because of bleomycin, busulfan, amiodarone and methotrexate, ARDS, radiation-induced lung injury associated with pro-inflammatory cytokine release. Example, TNF alpha, interleukin 1, interleukin 6 may be asymptomatic, but most common symptoms are dry cough and dyspnea with or without low-grade fever. Acute radiation pneumonitis develops within 3 to 12 weeks. That's the exudative phase. Radiation fibrosis may develop after 6 to 12 months. Next condition is idiopathic pulmonary fibrosis, where there is a progressive fibrotic lung disease of unknown etiology. May involve multiple cycles of lung injury, inflammation and fibrosis. It is associated with tobacco smoking, environmental pollutants, genetic defects. Findings are progressive dyspnea, fatigue, non-productive cough, crackles and clubbing. Imaging shows peripheral reticular opacities with traction bronchiectasis with or without honeycomb appearance of the lung. That is an advanced disease. Histologic pattern: usual interstitial pneumonia, There is decrease in type 1 pneumocytes, increased type 2 pneumocytes and increased fibroblasts. Complications are pulmonary hypertension, right heart failure, arrhythmias, coronary artery disease, respiratory failure, lung cancer. Next condition is hypersensitivity pneumonitis. It is mixed type 3 or type 4 hypersensitivity reaction to environmental antigens such as thermophilic actinomyces and aspergillus, often seen in farmers and bird fanciers. Acutely causes dyspnea, cough, chest tightness, fever, headache. Often self-limiting if stimulus is removed. Chronically, it leads to irreversible fibrosis with non-caseating granuloma or alveolar septal thickening and traction bronchiectasis. Next condition is sarcoidosis, which is characterized by immune-mediated widespread non-caseating granulomas. This figure is showing non-caseating granulomas, elevated AC levels and elevated CD4-CD8 ratio in bronchoalveolar lavage fluid, more common in black females, often asymptomatic except for enlarged lymph nodes. Chest X-ray shows bilateral adenopathy and coarse reticular opacities. In this film. CT of the chest better demonstrates the extensive hilar and mediastinal adenopathy. It can be associated with bell palsy, parotid enlargement, granulomas. Granulomas are non-caseating epithelioid containing microscopic Schumann and asteroid bodies. There can be rheumatoid arthritis like arthropathy and increased ocular uveitis, interstitial fibrosis, vitamin D activation due to an increase in the 1-alpha hydroxylase in macrophages and skin changes like lupus pernio or erythema nodosum. So sarcoids is the pneumonic. Treatment is glucocorticoids if symptomatic. Next condition, mesothelioma, that is malignancy of the pleura associated with asbestosis, may result in hemorrhagic pleural effusion, which is exudative, and pleural thickening can be there. Histology may show psammoma bodies. Electron microscopy shows polygonal tumor cells with microvilli, desmosomes and tonofilaments. Calretinine and cytokeratin 5 or 6 present in almost all mesotheliomas but not in most carcinomas. Tobacco smoking is not a risk factor for mesothelioma. Next, talking about pneumoconiosis. Asbestos is from the roof, what is common in insulation, but it affects the base or the lower lobes. Silica, coal and berries are from the base, that is the earth, but it affects the upper lobes or the roof. So asbestosis related disease. Asbestos causes asbestosis, pulmonary fibrosis, pleural disease, malignancies associated with shipbuilding, roofing, plumbing. Ivory white, calcified, supradiaphragmatic and pleural plaques are pathognomonic. There can be risk of bronchogenic carcinoma more than the risk of mesothelioma. There is increased risk of Kaplan syndrome because of rheumatoid arthritis and pneumoconiosis with intrapulmonary nodules. It affects the lower lobes. Asbestosis or the asbestos bodies. Ferruginous bodies are golden brown fusiform rods resembling dumbbells found in alveolar sputum sample visualized using Prussian blue stain, often obtained by bronchoalveolar lavage. There is increased risk of pleural effusions. Next condition, berylliosis. It is associated with exposure to beryllium in aerospace and manufacturing industries. Granulomatous, non-caseating on histology and therefore occasionally responsive to glucocorticoids. There is increased risk of cancer and cor pulmonale. Affects the upper lobes. Coal workers pneumoconiosis due to prolonged coal dust exposure. Macrophages laden with carbon leads to inflammation and fibrosis. It is also called as a black lung disease. Increase in the risk of Kaplan syndrome. It again affects upper lobes. Small rounded nodular opacity seen in imaging. Anthracosis. It is an asymptomatic condition found in many urban dwellers due to exposure to sooty air. Next condition is silicosis. It is associated with sand blasting foundries and mines. Macrophages respond to silica and release fibrogenic factors, leading to fibrosis. It is thought that silica may disrupt phagolysosomes and impair macrophages, increasing the susceptibility to tuberculosis. Increased risk of lung cancer, cor pulmonale, and Kaplan syndrome. It affects upper lobes. Eggshell calcification of hilar lymph nodes are seen on X-ray. The silly egg sandwich I found is mine. So this is for mnemonic to remember something about silicosis. Silly is silicosis. Egg sandwich is eggshell calcification. Sand is for sand blasting foundries and mines. Found and mine. So again, asbestosis is from the roof. So it affects the base. All the other silica, coal and berries are from the base. That's why it affects the roof. Roof is upper lobes. Next condition is acute respiratory distress syndrome. The pathophysiology is there is an alveolar insult which releases the pro-inflammatory cytokines which causes neutrophil recruitment, activation and release of toxic mediators like reactive oxygen species, proteases, etc., which in turn causes capillary endothelial damage and an increase in the vessel permeability. It increases leakage of protein-rich fluid into alveoli with formation of intraalveolar hyaline membranes. Here we are showing this intraalveolar hyaline membranes are seen here. And non-cardiac pulmonary edema, normal PCWP, decrease in the compliance and VQ mismatch, which causes hypoxic vasoconstriction, in turn increases the pulmonary vascular resistance. So there is loss of surfactant also contributes to alveolar collapse. That is seen in preterm infants and drowning. Causes of ARDS, most common is sepsis. Other causes aspiration pneumonia, burns, trauma, pancreatitis, drowning injuries. Diagnosis of exclusion with the following criteria. The ARDS itself is the mnemonic. A for abnormal chest X-ray, that is with bilateral lung opacities. R for respiratory failure within 1 week of alveolar insult. D for decreased PaO2 FiO2 ratio less than 300. And hypoxemia due to increased intrapulmonary shunting and diffusion abnormality. S for symptoms of respiratory failure and are not due to heart failure or fluid overload. Consequences are impaired gas exchange, decrease in the lung compliance and pulmonary hypertension. Management, treat the underlying cause. Mechanical ventilation, there is decrease in the tidal volume and increase PEEP, which keeps the alveoli open during expiration. Next condition, sleep apnea. There is repeated cessation of breathing more than 10 seconds during sleep, which causes a disrupted sleep and daytime somnolence. Diagnosis confirmed by sleep study. Nocturnal hypoxia can lead to systemic and pulmonary hypertension and arrhythmias. It could be atrial fibrillation or flutter and sudden deaths. There is hypoxia which increases the EPO, erythropoietin release, and increase in the erythropoiesis. Obstructive sleep apnea and central sleep apnea, obesity, hypoventilation syndrome are the three conditions where there is sleep apnea. So obstructive sleep apnea, the respiratory effort against airway obstruction. So PaO2 is usually normal during the day, associated with obesity, loud snoring, daytime sleepiness, usually caused by excess parapharyngeal or oropharyngeal tissue in the adults, adenotonsillar hypertrophy in children. Treatment by weight loss, CPAP, dental devices, hypoglossal nerve stimulation and upper airway surgery. Next, central sleep apnea. There is an impaired respiratory effort due to CNS injury or toxicity, congestive heart failure or opioids. May be associated with Cheyne-Stokes respiration, that is oscillation between apnea and hyperpnea. Treatment is positive airway pressure. Other type of apnea is obesity hypoventilation syndrome, also called as a Pickwickian syndrome, with an obesity of BMI of more than or equal to 30 kg per meter square. There is hypoventilation, increased PaCO2 during waking hours, so there is retention, and decreased PaO2 and increased PaCO2 during sleep. Treatment is weight loss, positive airway pressure. Next condition, pulmonary hypertension. Elevated mean artery pressure, pulmonary artery pressure. So elevated mean pulmonary artery pressure, that is more than 20 millimeters of mercury at rest. It results in arteriosclerosis, medial hypertrophy, intimal fibrosis of pulmonary arteries, plexiform lesions. So there is an increased pulmonary vascular resistance, increases the right ventricular pressure, right following leads to RVH, or the right ventricular hypertrophy. On examination, there is a parasternal heave and right ventricular failure. Etiologies for pulmonary hypertension are pulmonary arterial hypertension, group 1, left heart disease, lung disease or hypoxia, chronic thromboembolic, and multifactorial. So coming to pulmonary arterial hypertension is often idiopathic. Females have more incidence than males. Heritable PAH can be due to an inactivating mutation in the BMPR2 gene, which normally inhibits the vascular smooth muscle proliferation. It has a poor prognosis. Pulmonary vasculature endothelial dysfunction leads in increase in the vasoconstrictors like endothelin and decrease in vasodilators like nitric oxide and prostacyclins. Other causes can include drugs like amphetamines, cocaine, connective tissue diseases, HIV infection, portal hypertension, congenital heart disease, schistosomiasis. Next, group 2 is left heart disease. It causes can include systolic or diastolic dysfunction and valvular disease. Then lung diseases or hypoxia comes to group 3, destruction of because of destruction of lung parenchyma in COPD, lung inflammation or fibrosis in interstitial lung disease, hypoxemic vasoconstriction in case of OSA and or living in high altitude. Chronic thromboembolic comes to the group 4, causes of group pulmonary hypertension. Recurrent microthrombi can decrease in the cross-sectional area of the pulmonary vascular bed. Multifactorial or the last group 5. It causes can include hematologic, systemic and metabolic disorders along with compression of the pulmonary vasculature by a tumor. So we look at physical findings in select lung diseases. First, pleural effusion, the abnormality pleural effusion. There is a decrease in breath sounds. On percussion, dullness, the fremitus is decreased and tracheal deviation is none if small and away from the side of the lesion if large. In atelectasis also the breath sounds are decreased, percussion note is dull, fremitus is decreased and towards the side of the lesion there is tracheal deviation. In simple pneumothorax, again breath sounds are decreased. On percussion there is hyperresonance, fremitus is decreased and there is no tracheal deviation. In tension pneumothorax, decrease in breath sounds, percussion shows hyperresonance, fremitus is decreased and tracheal deviation is away from the side of the lesion. In consolidation, it could be lobar pneumonia or pulmonary edema. There is bronchial breath sounds and late inspiratory crackles, egophony, whispered pectoraliquy. In percussion shows dull note, fremitus is increased and there is no tracheal deviation. Next, digital clubbing. There is an increased angle between the nail bed and the nail plate, so more than 180 degrees. Pathophysiology is not well understood in patients with intrapulmonary shunt. Platelets and megakaryocytes become lodged in digital vasculature, which causes a local release of PDGF and VEGF. It can be hereditary or acquired. Causes include respiratory diseases like idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, and lung cancer. Cardiovascular disease like cyanotic congenital heart diseases, infections like lung abscess or tuberculosis, and others like IBD. Not typically associated with COPD or asthma. Next, coming to atelectasis. Atelectasis, there is an alveolar collapse, that is right upper lobe collapse against mediastinum is seen here in this picture. Multiple causes. One is obstructive, that is airway obstruction prevents the new air from reaching the distal airways. Old air is reabsorbed. Example, foreign body, mucus plug and tumor. Compressive type, external compression on the lung decreases the lung volumes like space occupying lesions or pleural effusion. Second feature is compressive type. This first one is obstructive type. Contraction or cicatrization, that is scarring of the lung parenchyma, can distort the alveoli, seen in sarcoidosis. Adhesive is due to lack of surfactant. Example, NRDS in premature infants. It is decreased via incentive spirometry or increased PEP during mechanical ventilation. That is for treatment of atelectasis. Pleural effusions. Next condition is pleural effusions. There is excessive accumulation of fluid between the pleural layers, which restricts the expansion of the lung. So it can be treated with thoracocentesis to remove or reduce the fluid. It is shown in B. After treatment, what happens to this image? There is a decrease in the fluid. So based on the Light's criteria, fluid is consistent with an exudate if pleural fluid protein and serum protein ratio is more than 0.5. Pleural fluid LDH and serum LDH is more than 0.6, or pleural fluid LDH is more than 2/3 of the upper limit of the normal serum LDH. Exudate is cloudy fluid. It's a cloudy fluid. Is cellular. Due to infection, pneumonia or tuberculosis, malignancy, connective tissue disease, and lymphatic or chylothorax and trauma. Often requires drainage due to increase in the risk of infection. Transudate is a clear fluid. It is usually hypocellular due to increased hydrostatic pressure. It could be heart failure, sodium retention, or a decrease in oncotic pressure in nephrotic syndrome or cirrhosis. Coming to pneumothorax. Pneumothorax is accumulation of air in the pleural space. So we are seeing this air accumulation in the pleural space. The symptoms can be dyspnea, uneven chest expansion, chest pain, decreased tactile fremitus, hyperresonance, and diminished breath sounds, all on the affected side. There can be primary spontaneous pneumothorax, which can happen due to rupture of the apical subpleural bleb or cyst. Occurs most frequently in tall, thin young males associated with tobacco smoking. Secondary spontaneous pneumothorax is due to diseased lung, like Bulle emphysema or Marfan syndrome and infections. Mechanical ventilation also with use of high pressures can cause barotrauma. Traumatic pneumothorax is caused by blunt, example like a rib fracture, penetrating like a gunshot, or iatrogenic like a central line placement, lung biopsies, barotrauma due to mechanical ventilation traumas. Tension pneumothorax can be from any of the above. Air enters the pleural space but cannot exit. Increased trapped air, so it causes tension pneumothorax. The trachea deviates away from the affected lung, may lead to increased intrathoracic pressure, causes mediastinal displacement and kinking of IVC. There is a decrease in the venous return, which causes decreased cardiac output, and obstructive shock, where there is hypotension and tachycardia, and jugular venous distension. It needs immediate medial decompression and chest tube placement. Next, coming to pneumonia. Pneumonia, there are different types of pneumonia: lobar pneumonia, bronchopneumonia, interstitial pneumonia, cryptogenic organizing pneumonia, aspiration pneumonia. So lobar pneumonia organisms are S. pneumonia, most common Legionella. Most commonly it is a pneumonia, S. pneumoniae. Others are Legionella and Klebsiella. Characteristic is intraalveolar exudate, which causes consolidation, may involve the entire lobe or the whole lung. Bronchopneumonia is caused by S. pneumonia, S. aureus, H. influenza, and Klebsiella. Acute inflammatory infiltrates from the bronchioles into the adjacent alveoli, which can cause patchy distribution, usually involves more than or equal to one lobe. In interstitial pneumonia or the atypical pneumonia, organisms are Mycoplasma, Chlamydophila pneumoniae, Chlamydophila psittaci, Legionella, Coxiella burnetii, and viruses like RSV, CMV, influenza, adenovirus. Here there is diffuse patchy inflammation which is localized to interstitial areas at alveolar walls. Chest X-ray shows bilateral multifocal opacities and generally follows a more indolent course, also called as a walking pneumonia. Next type is cryptogenic organizing pneumonia. Etiology is not known. No sputum and blood cultures often responds to glucocorticoids but not to antibiotics. It is formally called as bronchiolitis obliterans organizing pneumonia, also BOOP. Non-infectious pneumonia characterized by it is a non-infectious pneumonia which has inflammation of the bronchioles and surrounding structures. Next is aspiration pneumonia. There is aspiration of oropharyngeal or gastric contents which causes pulmonary infection. Risk factors are altered mental status because of which there is a decreased cough reflex or glottic closure, and other risk factors are dysphagia, neurologic disorders like stroke, invasive tubes like nasogastric tube. Characteristics: it presents days after aspiration, event in the dependent lung segment. So more common in the right lower lobe if sitting up and right upper lobe if lying down, or recombinant due to bronchial anatomy. It can progress to abscess. Aspiration pneumonitis or chemical pneumonitis presents hours after aspiration event due to gastric acid mediated inflammation. It presents with infiltrates in the lower lobes and resolves with supportive treatment. So the natural history of lobar pneumonia. So in the first 2 days there is congestion. Congestion shows red purple partial consolidation of parenchyma, and the exudate is mostly with bacteria. This is the first stage, congestion. Next becomes red hepatization. That is 3 to 4 days. There is red brown consolidation, and exudates are with fibrin bacteria, RBCs, WBCs, which is also a reversible stage. Next is grey hepatization, that is 5 to 7 days. Uniformly grey, exudate is full of WBCs, lysed RBCs, and fibrin. Resolution stage is after 8 plus days. There is enzymatic digestion of the exudate by the macrophages. So these are the stages. This is the normal lung. Next condition, lung abscess is localized collection of pus within parenchyma. It is caused by aspiration of oropharyngeal contents, especially in patients predisposed to loss of consciousness like alcohol overuse or epilepsy or bronchial obstruction in case of cancer. Air fluid levels are often seen on chest X-ray. Presence suggests cavitation due to anaerobes like bacteroids, fusobacterium, Peptostreptococcus or Staph aureus. Treatment is antibiotics, drainage or surgery. Lung abscess secondary to aspiration is most often found in the right lung. Location depends on the patient's position during aspiration, right lower lobe if upright, right upper lobe or right middle lobe if recumbent. Here what we are seeing is a lung abscess. Next, coming to lung cancer. It is the leading cause of cancer death. Presentation is cough, hemoptysis, bronchial obstruction, wheezing, pneumonic coin lesion on chest X-ray or a non-calcified nodule on CT. Site of metastasis from lung cancer is liver, which is characterized by jaundice or hepatomegaly, adrenals, bone, which can cause pathologic fracture, brain, so lung mets, so lung affective bone heads and brainiacs. It is a mnemonic to remember, lung metastasis. In the lung metastasis, usually multiple lesions are more common than primary neoplasms. Most often is from the breast, colon, prostate and bladder cancer. Sphere of complications. To remember, the mnemonic is sphere. So the complications due to lung cancer: superior vena cava, S for superior vena cava or the thoracic outlet syndrome, P for Pankos syndrome, Horner syndrome H, E for endocrine or the paraneoplastic syndromes, R for recurrent laryngeal nerve compression which causes hoarseness, E for effusions, could be pleural or pericardial. Risk factors include tobacco smoking, secondhand smoke, radiation, environmental exposure like radon or asbestos, pulmonary fibrosis and family history. Squamous and small cell carcinomas are central and often caused by tobacco smoking. Hematomas are found incidentally on imaging, appearing as well circumscribed masses. So we'll look at the different types of lung cancers. First is the small cell or the oat cell carcinoma, usually located centrally. Characteristics are it is undifferentiated and very aggressive. May cause neurologic paraneoplastic syndromes like Lambert, Eaton myasthenic syndrome, paraneoplastic myelitis, encephalitis, subacute cerebellar degeneration, and endocrine paraneoplastic syndromes like Cushing syndrome, SIADH. Amplification of the myc-oncogenes are common, and it's managed with chemotherapy with or without radiation. Histology shows a neoplasm of neuroendocrine Kaczynski cells with small dark blue cells, chromogranin A positive, neuron specific enolase positive, and synaptophysin positive. That is about small cell. Next, the non-small cell carcinomas are adenocarcinoma, squamous cell carcinoma, large cell carcinoma, bronchial carcinoid tumor. So adenocarcinoma could be peripheral in location and most common primary lung cancer. Most common subtype in people who do not smoke. More common in females than males. Activating mutations include KRAS, EGFR, and ALK associated with hypertrophic osteoarthropathy or clubbing. Bronchoalveolar subtype is adenocarcinoma in situ. Chest X-ray often shows hazy infiltrates, which is similar to pneumonia. Better prognosis. Histology shows a granular pattern, often stains mucin plus. Bronchoalveolar subtype shows grows along alveolar septae. There is an apparent thickening of the alveolar walls. Tall columnar cells containing mucus is seen. Next is squamous cell carcinoma is central in location. There is an hilar mass which arises from the bronchus. There can be cavitation, cigarettes, and hypercalcemia. Produces PTHRP. And histology shows keratin pearls and intercellular bridges or desmosomes. Large cell carcinoma, it is peripheral in location, highly anaplastic undifferentiated tumor, strong association with tobacco smoking, may produce HCG, gynecomastia, and large breasts and large breasts, large cell carcinoma. So less responsive to chemotherapy, removed surgically with poor prognosis. Histology shows pleomorphic giant cells. Then bronchial carcinoid tumor, it is central or peripheral. It can be both central or peripheral in location with an excellent prognosis. Metastasis is rare. Symptoms are due to mass effect, can be wheezing or due to carcinoid syndromes like flushing or diarrhea. In histology, will show nests of neuroendocrine cells with the chromogranin A positive. So we are seeing Kaczynski cells here, small dark blue cells. Next is mucin stain positive. Mucin stain positive. C is hilar mass. We are seeing in hilar mass. And D for keratin pearls. E is showing pleomorphic giant cells. Next tumor is Pancoast tumor, also called superior sulcus tumor. The carcinoma that occurs in the apex of the lung may cause Pancoast tumor by invading or compressing local structures. Compression of the locoregional structures may cause array of findings. Some of the structures which are compressed are recurrent laryngeal nerve, which causes hoarseness. Stellate ganglion compression causes Horner syndrome, which includes ipsilateral ptosis, meiosis, and anhydrosis. Superior vena cava compression causes SVC syndrome. Brachiocephalic vein compression causes the brachiocephalic syndrome with the unilateral symptoms. Brachial plexus causes shoulder pain, sensory motor deficits with atrophy of the intrinsic muscles of the hand. Phrenic nerve compression causes the hemidiaphragm paralysis. There is hemidiaphragm elevation on X-ray. SVC syndrome, that is a superior vena cava syndrome. There is an obstruction of the SVC, like it could be thrombus or tumor, and impairs the blood drainage from the head. Facial plethora, note the blanching after the fingertip pressure here. And in the neck there is jugular venous distension and laryngeal or pharyngeal edema, and upper extremities there can be edema. So commonly caused by malignancies like mediastinal tumor mass or Pancoast tumor and thrombosis from indwelling catheters. It is a medical emergency. It can raise intracranial pressure if the obstruction is severe. It can cause headaches, dizziness, and increase in the risk of aneurysm or rupture of the intracranial arteries. Coming to the respiratory pharmacology, H1 blockers, also called as antihistamines, They are reversible inhibitors of H1 histamine receptors, may function as neutral antagonists or inverse agonists. First generation blockers are diphenhydramine, dimenhydrinate, chlorpheniramine, doxylamine. So names usually contain en, ein, n or 8. Clinical uses of these first generation H1 blockers are for allergy, motion sickness, vomiting in pregnancy, and sleep aid. Adverse effects are sedation, antimuscarinic, and anti-alpha adrenergic effects. Second generation H1 blockers are loratadine, fexofenadine, desloratadine, and cetirizine. Names usually end in adine. Cetirizine is a second generation agent. Second and cetirizine, just the mnemonic. Clinical uses for allergy. Adverse effects are far less sedating than first generation because of the decreased entry to the CNS. Next drug is dextromethorphan. It's an antitussive. It antagonizes the NMDA glutamate receptors, can act as a hallucinogenic dissociative agent similar to ketamine at high doses, and may be combined with bupropion as a fast-acting antidepressant. Synthetic codeine, it's also a synthetic codeine analog, has mild opioid effect when used in excess. Naloxone can be given for overdose. It also has mild abuse potential, may cause serotonin syndrome if combined with other serotonergic agents. Next, coming to pseudoephedrine phenylephrine. The mechanism is activation of alpha adrenergic receptors in the nasal mucosa causes local vasoconstriction. Clinical uses used to reduce hyperemia and edema. It is used as a nasal decongestant and it opens the obstructed eustachian tubes. Adverse effects are hypertension, rebound congestion, also called as rhinitis medicamentosa if it is used for more than 4 to 6 days. It is associated with tachyphylaxis, can also cause CNS stimulation or anxiety because of the pseudoephedrine component. Next, drugs for pulmonary hypertension. The drug is endothelial receptor antagonist. So the mechanism is it competitively antagonizes endothelin 1 receptors and decreases the pulmonary vascular resistance. It is also hepatotoxic, hence need to monitor LFT. Example is bosentan. Bosen. So N for endothelial receptor antagonist. PDE, next group is PDE inhibitors, which inhibits the PDE5 and which increases the cyclic GMP, thereafter thereby causing prolonged vasodilator effect of nitrous oxide. Also used to treat erectile dysfunction. It is contraindicated when taking nitroglycerin or other nitrates due to risk of severe hypotension. Example is sildenafil. So PDE5 inhibitors. Next is prostacyclin analogs. PGI2 or prostacyclin. It has direct vasodilatory effects on pulmonary and systemic arterial vascular beds. It inhibits platelet aggregation. Adverse effects are flushing and jaw pain. Example is ipoprostinol and iloprost. So this is the picture of the endothelium, basement membrane and smooth muscles. So three pathways: endothelin pathway, nitroxide pathway, and prostacyclin pathway for pulmonary hypertension. Next, coming to asthma, drugs of asthma. So bronchoconstriction is mediated by inflammatory processes and parasympathetic tone. Therapy is directed at these two pathways. One is inflammatory process, other is parasympathetic tone. So first is inhaled beta-2 agonists like albuterol, salmeterol, formoterol. They relax the bronchial smooth muscles. It can cause tremors and arrhythmias. Albuterol is a short-acting used for acute symptoms. Salmeterol and formoterol are long-acting. Inhaled or oral glucocorticoids are fluticasone budesonide. It inhibits the synthesis of virtually all cytokines. It inactivates NF-κB, the transcription factor that induces the production of TNF-alpha and other inflammatory agents. It is the first line therapy for chronic asthma. Use a spacer or rinse mouth after use to prevent oral thrush. Next group is muscarinic antagonists. Examples are tiotropium, ipratropium. They competitively block the muscarinic receptors, preventing bronchoconstriction. Also used for COPD. Tiotropium is long acting. Next group is anti-leukotrienes like montelukast, zafirlukast. They block the leukotriene receptors, cis-LT1, especially for good for aspirin-induced and exercise-induced asthma. Xylitol is 5-lipoxygenase inhibitor, decreases the conversion of arachidonic acid to leukotrienes. It is hepatotoxic. Next, anti-IgE monoclonal therapy, omalizumab. It binds mostly unbound serum IgE and blocks binding to FcERI. Used in allergic asthma with an increase in IgE levels resistant to inhaled glucocorticoids and long-acting beta-2 agonists. Next group, methylxanthines, theophylline, likely causes bronchodilation by inhibiting phosphodiesterase and increases the CAMP levels due to decreased CAMP hydrolysis. Limited use due to narrow therapeutic index. It can cause cardiotoxicity and neurotoxicity. It is metabolized by the cytochrome P450. Blocks the actions of adenosine. PDE4 inhibitors, example roflumilast inhibits phosphodiesterase. It increases the cyclic AMP, it causes bronchodilation and decreases the airway inflammation. It is used in COPD to reduce exacerbations. Chromones, Cromolyn prevents mast cell degranulation. It prevents acute asthma symptoms and rarely used. And anti-IL-5 monoclonal therapy, it prevents eosinophil differentiation, maturation, activation and survival mediated by interleukin-5 stimulation for maintenance therapy in severe eosinophilic asthma. Examples are mepolizumab, reslizumab against IL-5 and benzralizumab against IL-5 receptor alpha. That is the end of respiratory pathology and respiratory pharmacology.